Uh, he's very rightly mentioned, Dr. Parthasarthi and his teammates, that sulfonylurea are the most commonly used drugs. Every physician uses them, but we are very afraid to share about it. We are very afraid to talk about it. In the era of GLP-1 receptor analogs, especially the oral one, newer one, SGLT2, DP4 inhibitors, they become so cheap. So all are talking about those drugs. And sulfonylurea is supposed to be a poor man's diabetic drug, has gone in the backseat. Even the guidelines, they are giving it a backseat. But we in India, we know that it is to be used, and we are using still in each and every patient. So we'll go through this topic and understand whether sulfonylurea, the use in 2022, are they still relevant? And we'll be focusing mostly on the glimepiride molecule. There is a first generation sulfonylurea, second generation sulfonylurea. You are not talking about glibenclamide, Dionel, which you everybody must be knowing about it. We are talking about glimepiride, which is a neo generation sulfonylurea, second generation. Although it's an old molecule, but again, the focus again by glimepiride is still relevant in today's context when we are treating diabetic patients. So, as he mentioned, that India accounts for 1 in 7 of all diabetics worldwide. We have a second highest country with diabetes prevalence, and there are 74.2 million diabetics in 2021 as per now in the current census. So, we understand that certain misconceptions were associated with sulfonylurea, that they cause beta cell failure, they are not cardiovascular safe, all sulfonylureas are same, they cause severe weight gain, they cause severe hypoglycemia, have no pleiotropic effects. And all these points are relevant till now to some extent, but not all are true, as we'll see in the future study of this talk. So, beta cell degeneration, the more apt term. So we are talking about normal beta cells, and they produce insulin, and the challenge beta cells which produce insulin. Then the current theory is they become dysfunctional and they become dead, and then the insulin becomes zero, and the patient becomes having uncontrolled diabetes, and within 10-15 years of diabetes, we has to be put on insulin, and that is the current scenario. The new hypothesis is that there is there is a challenge beta cell in which insulin is being produced. As you know, in diabetic type 2 DM patients especially, it is initially hyperinsulinemia, and then there is a reprogram which is to produce insulin and glucagon. So these hypotheses coming up, to what extent we don't know, but not all is true that when we say that beta cells becomes dead, is not true. They are reprogrammed as the disease progresses. So decreasing postprandial C-peptide levels over time are not associated with the long-term use of sulfonylurea, as by this observational study published in Diabetes and Metabolism. They describe the changes over 10 years periods in HbA1c and beta cell function as assessed by postprandial C-peptide, C-peptide glucose ratio, and they assess whether sulfonylurea have a deleterious effect on the beta cell function. They found that it didn't support the notion that sulfonylurea as used in clinical practice is harmful to beta cell function, and also an increase in HbA1c was associated with the decrease in beta cell function. Beta cell function remained unchanged if glycemic control was improved. So dysglycemia was mostly important about the beta cell decrease in the beta cell function. Also, it was noted that long-term treatment with sulfonylurea had no effect on the long-term changes in the beta cell function. So poor glycemic control, not the sulfonylurea, was associated with the decrease in beta cell. This is very important. Till now, before this slide also, we had this hypothesis that beta cell, they cause, beta cell decrease in the beta cell function. They make it dead. But I've been using sulfonylureas for the last 20 years. And in fact, when we are giving insulin, then also we use some amount of sulfonylurea, and we know that it is not dead. It is that they are reprogrammed to a different function. So we have to control the glycemia, whatever way it is, by giving whatever medicine, we have to control the glycemia. We don't blame sulfonylurea because वो हमने दिया तो इसलिए खत्म हो गया. So we can always uh, uh, discredit sulfonylurea, that is the cause of beta cell failure, but that is not the true, as proven by this study. Even effects of exenatide, sitagliptin, or glimepiride on beta cell secretory capacity in early type 2 DM, they found that after 6 months treatment of exenatide or sitagliptin, they had no significant effect on the functional beta cell mass as measured by the beta cell secretory capacity, whereas glimepiride appeared to enhance beta cell secretion. We know that glimepiride, they are insulin secretagogue, so they increase the insulin secretion. But exenatide and sitagliptin had no effect on the functional beta cell mass. So again, this just to highlight that beta cell increases the insulin release from the sulfonylurea. They increase the insulin secretion for the beta cell, and they don't cause the beta cell death. So the myth is glimepiride causes beta cell failure. The fact is current literature does not support the notion that sulfonylureas are harmful to beta cell mass or function. On the contrary, sulfonylureas appear to improve the beta cell secretory capacity when used early in the course of type 2 DM. That is true. As the time passes, the secretory capacity of the beta cell, they decrease, and we have to add some more drugs to enhance the whatever the insulin the patient is producing. So we don't blame sulfonylureas for all the calamities seen by the diabetic patient. And we are very much aware that there is a complementary mechanism of action of sulfonylurea and metformin combination. Sulfonylurea, they improve beta cell function by increasing the beta cell secretion, and metformin, they have an insulin sensitizing property. They act on the liver. They help to resolve the insulin resistance. So by doing this, there is a decrease in the hepatic glucose overproduction. So both modern sulfonylurea and metformin reduces the hepatic glucose overproduction. So in a way, they are complementary in mechanism. And whatever the pleiotropic effects of sulfonylureas, very few people, they are aware of it. Insulin clearance, they inhibit the metabolic clearance of insulin. They inhibit the glucagon secretion from the pancreatic alpha cell. It increases the insulin sensitization, plus decreasing the insulin resistance in the peripheral tissues. Ischemic preconditioning is very important, because till now, whatever glimepiride or whatever sulfonylurea we were being given, it was shown that they cause cardiac failure, or they are not beneficial in cardiac patients. Because at that time, when the sulfonylureas came, it was not mandatory to do a cardiac safety trial, as the FDA has done now, that it is mandatory to conduct a cardiac safety trial. So that's why you'll not see any medicine like insulin or even sulfonylureas. They have undergone a cardiac safety trials to assess the MACE effects and the mortality benefit and hospitalization for heart failure. So, but this molecule, the second generation sulfonylurea, that induces the ischemic preconditioning, suppresses the ventricular tachycardia, lowers the blood pressure, and so help it is in fact of some amount of cardiac protection. It is antioxidative. It decreases the toxic adverse glycated products and S-rich products. It reduces the plasma vascular endothelial growth factor, and it induces the vascular health by improving the medium factors which are available for the vascular health. So in a way, they are pleiotropic effects which we are not talked about, but it helps to improve the cardiac function. It helps to stabilize the beta cell mass. It helps to decrease the insulin resistance. So second generation sulfonylurea is beneficial to some extent. And when we are selecting anti-hyperglycemic treatment in adults with type 2 DM, see a patient walks to a clinic with a sugar of 400, and if he is not insulopenic, you can understand by seeing the patient that he is not thirsty, he is not weak, he is not nauseating, he is not vomiting. So that means he's a stable diabetic patient. So nobody, nobody accepts insulin treatment. And whatever the guidelines say, the HbA1c is more than 9, 10, start insulin. You talk to a patient coming to your clinic for the first time, he'll run away from you. So what is the medicine you use? You use sulfonylurea and metformin. And both have high efficacy. The risk of hypoglycemia with sulfonylurea is there. With metformin, it is not there. Weight gain, some amount of weight gain is seen with sulfonylurea. Cardiovascular effects, they are both neutral. Cost is low. They are oral ways to oral by oral. They are given as oral tablets. They have neutral effects on the renal conditions. If the eGFR is going very low, less than 20-30 ml per minute, we don't give metformin. Similarly, we don't recommend sulfonylurea when eGFR is less than 30 because of risk of hypoglycemia. And gastrointestinal side effects, which we see with metformin, like diarrhea and nausea. So it is not seen with other drugs, but some patients do have complaint of diarrhea and nausea with metformin, if especially given of more than 2 grams. I have recently seen today only, I saw a prescription in which a physician endocrinologist has prescribed 3 grams of metformin with voglibose, with sulfonylurea, with insulin. If you give so many tablets and so many metformin, the patient will out to leave you and go to some other doctor. So be careful. Mostly I've seen in practice that patients, they to tolerate up to 1 gram of metformin very nicely. Beyond 1 gram, you have to be careful. If they have side effects, please be alert to the patient's complaint and ask them about the gas formation and diarrhea. And if there, so many patients of mine, they have gone to gastroenterologist getting endoscopy done, no result. When I stop metformin, they get all right. So some side effects are there, but as a clinician, you should be aware that these are the side effects and be aware what maximum dose of metformin should be given. If you take care, the drug is very beautiful. There is absolutely no weight gain, and there is a decrease in insulin resistance also. And it helps to potentiate the actions of various other medicines which we give with metformin. So now the question is, all sulfonylureas are same? No. The first generation sulfonylureas were tolbutamide, glibenclamide, glipizide, and moderns are glimepiride, gliclazide MR, glipizide MR, and gliclazide plain. So gliclazide MR is given in a single dose, and gliclazide has to be given in the BD dose. So why glimepiride is better than other sulfonylurea? Because of lesser weight gain, least risk of hypoglycemia, ability to augment both first and second phase of insulin release, and CV neutrality. And glimepiride metformin combination is always given as a first choice. With patient coming to you with high sugar levels, always you choose normally I also choose a glimepiride metformin, because you want that patient sugar comes down to a low level. Of the increased anxiety in the family, the patient minds, you have to show the results. Within 5 days, you will see the sugar on the lower side, at least reduced by half. Then the patient sticks to you, and then you can modify the treatment. Beware that whatever dose you give the first 5 days, you decrease them and add some other medicine so that it doesn't land up with hypoglycemia. So initial combination we give should be considered in patient presenting with HbA1c of around 8 or 9. We give 2 drugs, and compared to metformin up titration beyond half maximal dose, the addition of sulfonylurea to metformin demonstrate better glucose lowering, efficacy, safety, and tolerability. So this concept has gone, that you go to one drug and give to maximum dose. That concept was old concept. Nowadays, you start with 2 drugs if the HbA1c is very high, and then you up titrate or decrease the medicine as per you go forward. There is no way you start with metformin 500, go to 1 gram, then 2 grams, then you add another medicine. I think this way of treatment, whether it's blood pressure or sugar, is gone. And be aggressive, a little aggressive. Always better to start 2 drugs in a patient of high sugars, and then you up titrate as per the requirement. So I think this is very valid point. So various trials have been there with the randomized clinical trial with glimepiride plus metformin plus monotherapy. They all showed that addition of glimepiride in type 2 DM patient uncontrolled by metformin alone resulted in a superior glycemic control than metformin monotherapy. The combined use of glimepiride and metformin in a single presentation was efficacious and safe. See, pill burden is also reduced. Now the combination of glimepiride and metformin is a very small size tablet as compared to the previous large ones. So they're very easy to swallow also. So the tablets are fixed drug combination were more effective than metformin up titration because patients were easily taking it, easy to swallow. Plus the result when the patients see sugar coming from 400 to 200, they stick to you and continue the medicine. So modern sulfonylureas, glimepiride and gliclazide MR are effective and safe second-line agents in patients who have not achieved pre-decided glycemic targets with metformin. That is a grade A recommendation. And modern sulfonylureas are effective and safe as initial therapy if used in combination with lifestyle modification and metformin in patients with a baseline of HbA1c more than 7.5. So generally, patient coming to you, they are having 8.5 HbA1c. You can safely start with metformin and sulfonylurea. Suppose the patient is having HbA1c of 6.8, 6.9, 7.2, start DP4 inhibitor and metformin. Don't leave the patient on metformin alone. It's very important because metformin as a monotherapy has shown as various trials is now of disuse, and you have to start with the DP4 inhibitor if the sugar levels are on the borderline like 6.9, 7.2, as shown by the verified trial in the vildagliptin metformin trial. That and the benefit is the patient, once he gets a tablet, his sugar comes down, and if he doesn't have hypoglycemia, the patient will stick to the tablet. If the patient is given a high dose of sulfonylurea and has hypoglycemia, he will leave the tablet. He will search for Patanjali medicines and Ayurvedic medicines. So be sure that when you are prescribing these medicines, what dose you are giving. And suppose the patient is such a patient that he will not come to you, you can feel it. Then you can start with a DP4 inhibitor and metformin combination. But do start with dual therapy if the patient is seen for the first time. There is no concept nowadays, unless until the patient is allergic to metformin, not tolerating metformin. There is no nowadays concept of starting only metformin now. So sulfonylurea should be considered for use in combination with all classes of OADs except glenides. Glenides is again a insulin secretagogue. And if not used earlier, modern sulfonylureas may be preferred as a third-line agents for the management of uncontrolled diabetes with dual combination therapy, because as per the guidelines now, if the patient having cardiovascular disease, atherosclerotic disease or CKD, he has to be mandatory put on GLP-1 receptor analogs and SGLT2. And then if it's not controlled, then you think of sulfonylurea. So nowadays, the therapy is decided on the associated comorbid condition of a diabetic patient. So FDC containing sulfonylurea reduce the cost, offer convenience, improve the patient adherence. Hence, FDC of varying strengths of sulfonylurea metformin should be made available, while sulfonylurea plus other drugs may be considered. So this is the glimepiride efficacy. We all know that glimepiride, sulfonylurea have the maximum efficacy after insulin in reducing the HbA1c levels and reducing the glycemic levels. So all these studies have shown that glimepiride reduces sugar levels more than the DP4 inhibitors. And similarly with insulins, you can give with the basal insulin sulfonylurea, but be careful when you start with the basal insulin in the night. Don't give sulfonylurea because that will cause a fasting hypoglycemia. The bad point is the patient will leave insulin and leave you also. So it's very important to prevent hypoglycemia. If you want to give sulfonylurea, give in the morning and then start with basal insulin in the night. And modern sulfonylurea may be continued in the anteportal meal if premixed insulin is initiated in the OD dose. Short-acting sulfonylurea or glinides may be continued or added to the third meal with appropriate glucose monitoring if premixed insulin is initiated twice daily. So idea is not to start insulin with sulfonylurea. If you are starting insulin, be careful when to use sulfonylurea, or maybe start in the lower dose. So combination containing modern sulfonylurea can be used in elderly patients as they are associated with the low risk of hypoglycemia, but you have to be careful what dose you are giving to an elderly patient. This is the effect of the preconditioning as shown, that how does it affect the myocytes. It protects the potassium channels and inhibits the ischemic preconditioning. So second generation sulfonylurea is better than the first generation sulfonylurea. I will not go to the detail, it's very elaborative. So unconventional sulfonylurea glimepiride does not inhibit ischemic preconditioning. So risk of coronary artery disease associated with initial sulfonylurea in type 2 DM patients, a match control study was there, published in Science Direct, and it was to assess the risk of developing CAD associated with the initial treatment of type 2 DM with different sulfonylureas, and 20-year risk of CAD diagnosis of diabetes mellitus using UKPD's risk regime engine was used to match cases with controls. So what was the hazard of developing CAD associated with the initial treatment? There was 2.4-fold increase of cardiovascular event if they were used with glimepiride, 2-fold increase in cardiac events if glipizide was used, and 2.9-fold was with either of the medicines, and it was unchanged with metformin. Whether you give it in combination with metformin was not preventing cardiovascular disease. But when we see with glimepiride, there was 0.3-fold decrease in the cardiovascular event with glimepiride and 0.4-fold decrease in the cardiovascular event with gliclazide. So second generation sulfonylureas are better as compared to the older generation. I think nowadays we are not using any glibenclamide. Glipizide can be used in some renal patients because of short action, but we have to be very, very careful. So this is the timeline of cardiovascular safety for sulfonylureas. It was discovered by Lobatris in 1942. The glucose lowering effect of sulfonylurea was assessed. Then tolbutamide was marketed in 1956. Then second generation sulfonylurea, they came in 1980. A better safety profile was there. Then there were various trials of UKPDs, advanced, Tosca-IT, Carolina. Carolina is the latest trial in which glimepiride was assessed with linagliptin to assess the cardiovascular safety. Again, this trial proved that linagliptin was not inferior to glimepiride in increasing the cardiovascular event. So, in a way, glimepiride was also as safe as linagliptin for cardiovascular events in a Carolina trial. So, this is some flip side of Carolina. There was a screening, and then the patient was classified into a linagliptin 5 milligram per day, and glimepiride was given for 1 to 4 milligram per day as per the titration. And event-driven study was there, and then the patient was seen at the end of the treatment and then follow up to 23 days. So it showed that the trial had in this trial, 83% patients were on metformin, 6.3 years was the median duration of diabetes, 42% had established cardiovascular disease, 30% had additional 2 cardiovascular risk factors. So patients were having cardiovascular disease. 40% patients had diabetes for less than 5 years, and all were receiving the standard of care treatment for severe risks like statins and aspirin and all that. And there was no patient on insulin, and 9% were treatment naive. The number of patients was 6,033. So primary endpoint was to have any 3-point MACE effect like CV death, non-fatal MI, non-fatal stroke. And secondary endpoints was time to occurrence of 4-point MACE events and proportion of patient on treatment or maintaining HbA1c of less than 7% at final without need for rescue medication, moderate severe hypoglycemia, and more than 2% of weight gain. So this was the trial, and we found that the 3-point MACE events was similar as compared to glimepiride. So in a way, this trial was benefiting glimepiride rather than linagliptin. It showed that linagliptin was as safe, that glimepiride was as safe as linagliptin, vice versa. Linagliptin was non-inferior to glimepiride in cardiovascular risk over 6.5 years. Similarly, there was no increased death seen in the Carolina arm. Similarly, there was no increased death in the sulfonylurea arm. So both the molecules were equal in the time to CV death. They had no increased events, or the sulfonylurea was not showing any increased cardiovascular death as compared to the linagliptin trial. So in a way, this trial benefited glimepiride more than the linagliptin. So why this is important? Because we are afraid to use sulfonylurea because we have heard so many myths about it, that is not bad, it's bad, it is bad for the heart, it's bad for the, it will cause hypoglycemia, it causes weight gain. But you have to reduce HbA1c, because if we reduce 1% HbA1c by 1%, it will decrease 43% lower extremity amputation of fatal peripheral vascular disease. It will decrease 37% by vascular disease. 19% catheterization will be reduced. 16% heart failure will be reduced. 14% myocardial infarction will be reduced, and 12% stroke will be reduced. So you have a molecule, cheap molecule given with metformin. So we should not disregard this molecule. We can use this patient judiciously. Each and every molecule should be used judiciously. Don't give very, very high doses of metformin like 4 milligram BD or so many. I've seen patients. See, maximum benefit is seen by 4 milligram. 80% of benefit can be seen up to 4 milligram. Some may use up to 6 milligram but of glimepiride, but that will hardly improve the patient's profile. So I think no point in giving high doses of glimepiride. I've seen so many prescriptions, 8 milligram up to 8 milligram metformin given, tedious doses of metformin and glimepiride given. There is no advantage to it. So we have to use this molecule judiciously. It has results and it saves life. As a cheap man's drug also. So the myth was glimepiride is unsafe, just like other sulfonylureas. The fact is, cardiovascular safety of glimepiride is reassuring and may help patients with type 2 DM world over to avail the benefit of this affordable, efficacious medication. When we talk about cardiovascular safety, we talk about SGLT2, we talk about GLP-1 receptor analog in injectable form. Now there is oral GLP-1 receptor analog, which is very expensive. So you have a medicine, if you use judiciously, you can still save your patient from cardiovascular disease. I think this study everything has been gone so many times, but just to highlight that we have to start with metformin and lifestyle modification. And if the patient is having atherosclerotic disease and heart failure or CKD, we have to consider GLP-1 receptor analog or SGLT2. Then gradually we add more medicine if the HbA1c target is not achieved. And if basal insulin being used, so you should be very careful about using of sulfonylurea, and it will help to minimize hypoglycemia. Again, for weight gain and cost may, if you want to decrease the cost of the therapy, then sulfonylurea comes first. So in the present context, in the latest guideline also, sulfonylurea is not out, is still considered in some patients, although you may not give it in the initial line of treatment, but I think it's still being used, and I am still using in 80% of patients. They are still on sulfonylureas. So there are 33 guidelines they support globally the use of sulfonylureas, and they can be used in associated with the acarbose, SGLT2 inhibitor, thiazolone diandose, DP4 inhibitor. There are 16 trials, 14 trials, 13 trials, but sulfonylurea still have guidelines from 33 societies. They still support the use of sulfonylurea. And ADA recommends that combination therapy with any of the preferred 6 medication to achieve the HbA1c reduction are their preferred medications. They still include sulfonylurea, DP4 inhibitors, thiazolone diandose, GLP-1, the SGLT2, and basal insulin, apart from metformin. And patient-specific factors and drug-specific factors have to be studied. And sulfonylurea is still recommended as a third-line therapy in patients with type 2 DM and atherosclerotic CVD and CKD following failure of SGLT2 inhibitors or GLP-1 receptor analog. So sulfonylureas are not out. You may still use them. In individual patients without underlying cardiac or renal problems, you can use sulfonylureas as second-line therapy option when cost is a major factor. As I told you, there is no risk of established CKD, atherosclerotic disease, or heart failure, you can still use sulfonylurea. IDF also recommends the use of sulfonylurea when metformin is not tolerated. So sulfonylurea except glibenclamide and glyburate can be prescribed. Metformin can be combined with sulfonylureas except glyburate and glibenclamide, SGLT2 inhibitors, DP4 inhibitors. When starting on sulfonylurea, a patient should be educated how to prevent, recognize, and treat hypoglycemia. This is very important because once the patient is having hypoglycemia, he will leave you and he will change the doctor, or maybe change the branch of the medicine. ISPAD, sulfonylureas are not used for the use in patients of less than 18 years of age. Type 1 patients, we should not use them. People on sulfonylureas should be encouraged to do a self home monitoring blood glucose system to detect asymptomatic hypoglycemia. NICE, WHO, they all recommend the use of sulfonylurea. NICE recommend sulfonylurea as an initial treatment regimen in individuals who are intolerant to metformin. Use of insulin or sulfonylurea is recommended in patients with type 2 DM who are symptomatically hyperglycemic. So if high sugars, only these medicine will work. So recommended dual therapy with metformin and sulfonylureas in adults and type 2 DM patients whose HbA1c levels remain uncontrolled with initial metformin therapy. Similarly, WHO, ESD, ACE, they still recommend the use of sulfonylurea either alone or with metformin or in addition to other medicines if the patient are having uncontrolled hyperglycemia. So sulfonylurea can be used as monotherapy, as a second-line therapy, as a triple combination therapy, as a quadruple combination therapy with metformin, GLP-1 receptor analog, DP4 inhibitor, or metformin. It can be combined with insulins. Gliclazide and glimepiride may be used as second line with insulin-based therapies and metformin. It can still be used in elderly, although in the smaller doses. It can be used in Ramadan. Second generation like gliclazide and glimepiride are recommended. Avoid glibenclamide because of long duration of action. And even it can be used in CVD or renal impaired patient. But still you have to monitor the eGFR. If they are less than 30, be careful not to use them. So what are the practical tips with using sulfonylurea? Start low, step up slow. Start with a low dose, then gradually step up. And it should be done, titration should be based on glucose monitoring once in 2 weeks for responders with no hypoglycemia and once a week for non-responders with or without hypoglycemia. So should be given before the first and subsequent major meals of the day is important. Importance of adherence must be explained. Patient should be educated need to carry diabetes identity card, sick day management. Suppose the patient is having diarrhea. Nowadays, we are seeing a lot of patients with gastroenteritis. Please tell them not to take the medicine. They pop up the pill, they continue to go to the loo, and then they land in the hospital with hypoglycemia. This is very important. You should tell them not to take the medicine, sulfonylurea, especially if the patient is having diarrhea or vomiting, the loose motions or fever, high grade. Or they check their sugars and then they take the medicine. They should recognize and manage the hypoglycemia. You should de-escalate the dose of sulfonylurea as per the requirement. So modern sulfonylurea glimepiride scores over the conventional sulfonylurea due to the unique characteristic of increased efficacy, CV safety as proved by the Carolina trial, fewer episodes of hypoglycemia, weight neutralizing effects, and pleiotropic effects. Hence, should be preferred in the clinical practice. Thank you.
Thank you. Thank you very much, sir, for the wonderful session taken by you. It was very clean, very crisp, and was very practically taken. We do have a certain few questions that have come from the audience. So we have Dr. Yogendra Gupta who's asking, can we use glimepiride in cases of CKD? Of course, you have already hit on that, but
less than 30 eGFR should not be used, and then you have to be careful what dose you are giving it to a patient.
Absolutely.
You have a lot of diabetic patients, CKD patients also, and we are using sulfonylurea. Maybe we can start with the OD dose and gradually up titrate if required.
So, as far as the ADA 2022 guidelines are concerned, as far as the first line therapy was concerned, ADA till 2021 held metformin as the whole and soul first line therapy unless contraindicated. But in 2022, we saw ADA take a more broader stance, saying individualized patient care, personalize it, and the first line therapy would generally include metformin. But of course, you could individualize it based on patient preference. So are there any subsets of patients in clinical practice, though rare, are there any subsets which would benefit from a sulfonylurea alone?
Any young, healthy, young patient who is not insulopenic. See, it's very important to identify an insulopenic patient. A patient हट्टा कट्टा जैसे आता है, हट्टा कट्टा बिना कुछ दिक्कत के, जी मेरे को तो पता ही लगा आज 400 शुगर हो गई, उसको आप दे दो, क्या दिक्कत है उसको, मॉनिटर कर लो, 5 दिन के बाद दोबारा बुला लो. सो उसमें यू कैन गिव इट, क्योंकि if you want the patient sticking to you, you have to give sulfonylurea.
Sure.
This is the only medicine which will reduce your sugars by half by the end of 5 days. It will start with the mechanism of action works on the day 1 itself. The results are seen in the day 2 itself. So dramatic effects, and you can safely give it. Suppose the patient is a heart failure patient, MI patient, or frail patient, lean and thin, very sick. Why give sulfonylurea? There are so many medicines. So most of the clinics we have healthy हट्टा कट्टा जैसे कहते हैं, आते हैं young patient, दे दो उनको, क्या दिक्कत है?
So on the same note, you also mentioned the same point, phenotyping patients in clinical practice. Wonderfully, as you said, insulinopenic patients. So is it often that drugs sometimes get a bad name just as a result of poor phenotyping of patients, saying which patient should get the benefit of what therapy?
Bilkul, but sulfonylurea haven't got the bad name. These are only in the trials. You are getting a bad name. You ask any doctor from any country, sure, they're still using sulfonylurea.
Sure.
So just to, now वो ये बैंड बाजा बारात जिसका चल रहा है, वो अब DLP-1 एनालॉग्स एंड SGLT2 इनहिबिटर्स की बात होती है, कोई sulfonylurea की बात नहीं करता, क्योंकि 20 साल 25 साल से मैं ही इस्तेमाल कर रहा हूँ. So we are using it, but ठीक है. So ऐसा नहीं है, it's got a bad name, but the use, the amount of medicine, the sold glimepiride, I think the amount must be going up rather than going down. The number of diabetic patients we are seeing. So there is no way it's a bad name. It's just that you have to be careful when we use it, because they cause hypoglycemia.
Sure.
You have to prevent hypoglycemia, whatever medicine you use, whether you use insulin, SGLT2, although the chances of hypo is less, But when we combine with sulfonylurea, then chances of hypoglycemia increases. So we have to be very careful. If we use them judiciously, I yet to see any patient complaining about the use of these medicines. They don't work after some time. That is true.
Sure.
Because they don't decrease the insulin resistance. Metformin the patient can't tolerate. So you have to go for different ways to control diabetes, different mechanism of actions of various drugs.
Sure.
So it has a limited way to act. To some extent, it will work, but it will not go all through the time.
Sure. Hitting, as you rightfully said, hitting the ominous octet with multiple pathophysiologies,
That has to
multiple
be
drugs.
done. That has to be considered. So
And
this drug will not affect the octet. It will not have that effect. But whatever it has, it is still being used by every physician, I think.
So on the same note, considering you mentioned the word insulinopenic, possibly just going a little away from glimepiride but into SGLT2 inhibitors. Again, a beautiful class of drugs which received prime place in guidelines in patients with HFrEF, patients with CKD, patients with ASKD, and with positive trials ultimately saying, give this medicine irrespective of baseline HbA1c or target HbA1c, and irrespective of metformin use in these subset of patients. And again, here too, possibly not catching the insulinopenic patient and just giving it to that patient would possibly land him up in a DK.
Yes.
So a wonderful point highlighted by you once again. Sir, in the absence of any further questions, I believe we can close for the day.
Yeah, sure.
We would like to extend our thanks to you for the wonderful and very clinically relevant session. Each slide was also given your own clinical flair. You also discussed your own clinical points and caveats with the same. So we really thank you for the same. We also thank our esteemed audience for taking their time to be part of this session and enhance their knowledge, which would ultimately enhance and drive better patient care outcomes. Last but not the least, we also thank our technology partners for aiding us in the very smooth streaming of this webinar. Thank you one and all. Good night.
Thank you.
Thank you.
Thank you, sir. Thank you, sir. So can I end the meeting with your permission?
Yes, please.